this. Hold on one sec. That the inability to augment cardiac work was really what was responsible for a large proportion of the mortality in older adults. Now, one of the problems is that there we go. One of the problems is that pulmonary catheters are very invasive. I'm going to assume that the vast majority in the audience has no idea what I'm talking about. It's essentially a large catheter that is inserted into the central veins of the neck that goes through the heart, and you can kind of really measure some advanced pressures, overall function of the heart. The only problem is that it would mean that patients would have to present to the operating room, receive the catheter, and kind of get ready for the surgery, and then have it get canceled. It's not really a very efficient way to kind of move forward. And so it was thought that what is known as functional capacity, or the functional capacity assessment, which used exercise as the quote unquote stressor before surgery, would actually potentially be an improved method and a more efficient method to identify at-risk patients. Now, the definition of functional capacity is really the ability of an individual to perform aerobic work as defined by the maximal oxygen uptake, or VO2 max. And essentially, patients who have a strong heart can deliver oxygen to the periphery and perform work as it's suspected that the heart is primarily the limiting factor, at least in healthy individuals. It's typically done in terms of cardiopulmonary exercise testing or maximal exercise testing. There are some other tests that are available, such as a submaximal test, such as a 6-minute walk test, in which you measure the distance walked as a measure of overall functional capacity. You may know it also in terms of New York Heart Class associations, in terms of relation of heart failure, to identify whether patients have symptomatic limitations due to heart failure. And then the exercise itself measures multiple physiologic domains, such as cardiac, pulmonary, central nervous system, vascular, and also musculoskeletal. What that means, though, for patients that are not well, is that the limitations may not be necessarily cardiovascular specific. As you can imagine, someone with arthritis may have pain in the lower extremity, unable to do work, but that's not necessarily due to a primary cardiac limitation. Just to conceptualize what CPET typically looks like, it typically looks like this with an EKG and a expired gas analysis, and then the stressor itself is either a treadmill or a cycle ergometer, which provides the stress, and then there's monitoring in terms of EKGs for ischemia and expired gas analysis, which to look at oxygen consumption, carbon dioxide production, and that is how you actually identify the overall cardiac function and cardiorespiratory fitness, which, to be honest, is actually the strongest predictor of long-term all-cause mortality. And so CRF, or the ability to do cardiac work, is typically the strongest predictor of that. And in this prospective study of about 4,000 individuals with a single measurement of CRF in the 60s and 70s, followed for about 50 years, can identify that low fitness individuals have a much higher frequency of all-cause cardiovascular and cancer-related mortality, as opposed to the high fitness group, which had a overall frequency of 50 deaths per 10,000 person years. And you can see the separation in terms of the blue curves representing the low fitness group, whereas the, purple or dark blue, we're going to go purple, with the high fitness group as well. Now, the question really is that actually transferable to the perioperative period? And so the question would really be, so that's fine for long-term mortality, but what about in the kind of acute short-term to identify high-risk patients? And so this was a follow-up, again, to those pulmonary artery catheter studies, looking at exercise as that stress to identify high-risk patients with insufficient cardiovascular reserve. And they used, again, cardiopulmonary exercise testing and cycle ergometry to identify a different variant, but the anaerobic threshold, which is very similar to what's called peak oxygen consumption. And sure enough, in this older adult cohort, the mean age was 70 years of age. Overall, in hospital mortality was quite high, about 6%. So typical with kind of some studies that we've seen before. And sure enough, if you stratify by functional capacity as measured by the anaerobic threshold, you can see that using a cutoff of roughly 11 mLs per minute per kilogram, which is overall oxygen consumption at peak exercise, you can see that there's a significant difference in the frequency of in-hospital mortality of roughly 18% versus 0.8% or less than 1% between the two groups. And that's illustrated by the figure 3 on the right-hand side, which illustrates it very clearly. So the problem, though, with cardiopulmonary exercise testing is that it is time-consuming and requires money. And so there was a transition from objective measurements of either cardiovascular function or functional capacity as measured by anaerobic threshold to self-report. And so here is a study essentially of about 600 patients in terms of using self-reports of functional capacity to identify high-risk patients. This occurred in 1999, and they used 2 questions to identify what they termed as either functional capacity or exercise tolerance, which was how many blocks can they walk on level ground and how many flights of stairs can they climb. And the authors said that without experiencing symptomatic limitation is kind of how they phrased the actual question to the participants. That being said, they didn't actually specify what types of symptoms were actually limiting patients. And they didn't say if it was chest pain, shortness of breath, or any. They did specify in terms of 4 blocks and 2 flights of stairs was typically the threshold that they used to identify adequate versus inadequate functional capacity. And here was about 56% of the overall cohort, or 343 out of 612. And understandably, those patients were typically older, had heart failure, diabetes, and COPD, which is also understandable as those conditions would likely limit activity and also their exercise tolerance. The results of this study essentially generated that composite cardiovascular outcomes were, of course, higher in poor functional capacity patients. Those were typically 9.6% versus 5.2%. What's fascinating about this finding is, and this included, in-hospital mortality or all-cause mortality as well, was that, and I assume many know about the Fragility Index, but the Fragility Index is essentially a measure of the fragility of the statistical analysis, so that if one of the outcomes or if a number of outcomes happen to change from one group to the other, or it actually just did not occur, in this case, if a composite cardiovascular outcome did not occur in the poor functional capacity group, then the finding would have been non-significant. And so essentially, if one patient switched groups, the entirety of the study's hypothesis would have been rejected, and we would accept the null, but self-report may not actually be an effective means to identify high-risk patients. Nonetheless, this is actually what became accepted in terms of the adoption of clinical practice guidelines that we use, and why I say me, I use, and maybe Dr. Hussein she's in her practice, to risk stratify patients before surgery, which is a stepwise approach to identify high-risk patients that use self-report functional capacity. And the guidelines suggest a threshold of 4 metabolic equivalents. So essentially, you have to identify activities that are associated with 4 mets that individuals who are presenting for surgery are able to achieve. And suggested guidelines are essentially walking up a flight of stairs, walking at 4 miles an hour, walking 2 to 3 blocks. They actually say ballroom dancing is not apparently 4 metabolic equivalents. I'm actually not kidding. They do cite ballroom dancing. That has significant patient implications as well, partly because those patients deemed to have poor functional capacity may be referred for additional stress testing. Now, initially, you think that might be a good thing given what we've talked about historically, but unfortunately, these are pharmacological stress tests. They don't actually necessarily look at reserve, but mainly the ischemic fraction of cardiovascular disease or coronary artery disease. And they use also clinical risk factors to help guide that decision at the bottom of that flowchart. I'm not going to go into the nitty gritty, just to know that those clinical factors are also known as the RCRI, or the Revised Cardiac Risk Index. And we'll use those to help kind of guide the study that I'm going to talk about in a second. And as you can imagine, in response to those guidelines, preoperative cardiac stress testing actually increased dramatically in the mid to late 90s, up until early 2000s is when this study kind of was completed in 2007. And essentially, this is a 5% sample of Medicare patients who are undergoing low-risk surgery and are nonetheless being tested, despite that the guidelines would recommend that they don't need it. And it's roughly up to about 6 to 7% frequency of those patients before. And so I kind of present all that to kind of frame these 2 studies that I'm going to talk about, at least initially, which is over the last 20 years, a dramatic change has occurred in the preoperative assessments, and the critical decisions became adopted based off of shaky evidence, which is to say, can we use self-reported functional capacity? And of those self-report, what patients say they do they actually do it? And then also looking at pharmacological stress testing as compared to exercise tolerance in terms of was partly driven by financial incentives. And so we're going to evaluate those two aspects of the guidelines in a couple of papers that I wrote that also Dr. Huizencheeks participated on, at least within the first one. And just to kind of give you some degree of context, because I assume most people aren't doctors here, there were 48 million surgical procedures performed in the United States in 2009. That has only increased in the interim. And so these assessments are performed millions of times a year. And this is roughly what physicians rely on in moving forward. And so the first paper we're going to talk about is the accuracy of physical function questions to predict moderate and vigorous physical activity as measured by hip accelerometry. And the study question essentially is to determine if individual physical activity questions accurately identify individuals with an adequate functional capacity. That's the first aim of the study. And the second is that to identify differences in overall activity between individuals with and without inadequate functional capacity, essentially trying to look at whether it's a very small aspect of activity and otherwise the kind of patients are the same, or if there are overall kind of differences in their activity intensities or overall active time based on other characteristics. So we're going to start with the data source that we used for this study. And we chose the National Health and Nutritional Examination Survey, or NHANES, to kind of evaluate this question. And we wanted a nationally representative sample because this is a nationally representative problem or kind of clinical question. And also what we didn't want was to get a kind of select group within our institution that may not necessarily represent that. And also that anybody could really be a surgical patient presenting for a non-cardiac operation. The other advantage of using NHANES is that it oversamples older adults, essentially those over 70 years of age, which was of interest to us mainly because those are the individuals who have a poor functional capacity. That typically speaking, they're less likely to engage in moderate activity. And so by oversampling, it will make sure that we have a reasonable sample of adults that would fit into that category of poor functional capacity. Additionally, it oversamples low income, non-Hispanic, Black, and also Mexican Americans. And so it's really a nice representative sample. Where we focused our study on was on the accelerometer sub-studies in terms of 2 waves. Now, I guess I could say that NHANES has had 4 waves of accelerometer sub-studies. One is in 2003-04 and also 2005-06. That used hip-worn uniaxial accelerometers. The more recent waves are wrist-worn, which I'm going to talk about in a second and how that differs. But we used hip-worn because it's much more reliable in terms of assessing for activity intensity and identifying that activity intensity that older adults or adults would actually be engaged in, and was typically characterized by a 7-day wear time, which is pretty standard, and also accompanied by a detailed physical functional questionnaire, which I'll talk about in a second. Now, just a kind of a brief discussion about accelerometers, partly because I'm not sure if everybody's necessarily familiar with them, but essentially they're called accelerometers because they measure accelerations over time. It's typically in terms of gravitational units, and those gravitational units are then transformed, usually based on either proprietary open source software, to transform into what was considered a unitless count variable, which is then aggregated into discrete kind of time periods and is directly associated or correlated with activity intensity. And so that's how those monitors typically can identify the presence or absence of activity, and then the actual activity intensity as kind of typically broken down into light, moderate, or vigorous, or actually the absence of activity, which would be sedentary behavior. The data itself is typically summarized into discrete periods of time, which can vary the actual interpretive measurements. Usually 1 minute is a common unit of measurement for this type of approach, which would rely on counts to identify activity intensity. And that's exactly what NHANES actually did. In terms of wear location, and I mentioned that NHANES has had 2 different kind of versions of monitoring for those participants. You can wear it on any limb. As you can see, the picture here suggests that this individual is wearing it on the hip and also on the wrist. And that matters in terms of the ability to interpret the data that is associated with that wear time in terms of the reliability for the activity intensity, which is associated with it. I happen to be a very kind of a hand talker sometimes. And so if I was wearing a wrist accelerometer, then that would be kind of likely that it may be over sensing and suggesting that I'm being very active, even though I'm actually just sitting talking to you guys right now. Whereas on my hip, it's obviously much harder to actually kind of develop a certain intensity of counts or activity counts. And so the reliability of activity intensities is much stronger for hip-worn devices, which is why we relied on these samples as opposed to the wrist-worn, which would be in the samples, I believe it was 2011, 12, and also 13, 14, I think is roughly around those times, in which case that's when those were used. Here is a kind of to give you some kind of context of what the data actually looks like. Here's a sample of a 70-year-old female living at home wearing a hip-worn accelerometer. And the x-axis is essentially time. This is only one day of actual accelerometry. And so it's from 12 a.m. to 12 p.m. And then this kind of identifies the overall frequency of activity, and the intensity itself is on the y-axis, this being light activity and this being moderate. Now, this is not a uniaxial accelerometer. This is not exactly the same that was used in NHANES. This is a triaxial, so it measures different axes, which is why there are two different colors of counts here, and those are typically summed together to create a variable called counts per minute. Actually, one last thing. What she was doing at midnight, I can only imagine what a 70-year-old lady is doing at midnight, because I would be fascinated by that. And the fact that she is as active makes me feel old, even though
obviously going to the bathroom.
That's kind of what I figured. I'm not going to lie. I thought that she was probably making a pit stop there, but it seems like it's a little bit prolonged. Like it took some time, but maybe she had to get back in bed or whatnot. But nonetheless, it is fascinating what you can infer from people's activities in looking at that. Now, in terms of the dimensions of physical activity, accelerometers can't necessarily measure all of those different dimensions. In terms of the four that are commonly referred to when you think about activity, or at least physical activity, the mode is essentially a specific activity being performed, and accelerometers are actually quite poor at identifying that unless it's actually kind of walking, in which case steps can typically be identified or measured based on those proprietary algorithms. That being said, for older adults, steps should not necessarily be relied upon sometimes, because the actual threshold of older adults and their activity intensity may be quite poor. Some advanced accelerometers or actual wearable devices like the Apple Watch has gotten a lot better at being able to identify certain activities on individuals repeatedly over time, but that is still kind of being worked out. In terms of the frequency, essentially is the number of sessions per day, and the duration is essentially the time spent doing the activity itself. And then there's the intensity, which is really the crux of what we were looking at or trying to identify, with essentially older adults engaged in moderate activity intensity. So it's the rate of energy expenditure and the metabolic demand of that activity, which is what we're trying to relate to identify those who may be at risk of perioperative complications. And so for this study, our primary outcome was moderate to vigorous physical activity. And we combined moderate and vigorous partly because the frequency of vigorous activity in older adults is exceptionally poor. And so they typically don't engage in that. And so whatever was there, we combined it to one, as opposed to have like 0.05% of any kind of vigorous activity. And so we combined those two intensities. What was surprisingly unknown, though, by the guidelines or from the guidelines is how long a bout of moderate to vigorous physical activity needs to be maintained. Essentially, the duration of that activity intensity, how long should it actually exist for? And the guidelines aren't clear. They just give you activities and a certain threshold. So one of the co-authors on this paper was a guy named Ross Arena, who authored the American Heart Association's statement on functional capacity assessment for research conditions, which actually kind of was very helpful for us. And so we had a long discussion, and it's important to provide that historical context that cardiopulmonary exercise testing was actually the kind of, driving force behind assessing functional capacity, partly because CPET is divided into stages. And typically active stages are roughly about 2 minutes in duration. And so somebody who's able to complete one stage, which starts at 4 metabolic equivalents, is then usually moved on to the next stage in intensity. So that's ramped up typically for cardiopulmonary exercise testing. And so based on that, we felt that 2 minutes was likely a sufficient volume or time period to identify. And so we were looking for at least one bout of 2 minutes of moderate to vigorous physical activity. And that's how we interpreted the guidelines. That being said, we did something else a little bit, which was, I guess you could say, a little bit fun and kind of concordant with what we had decided. But in terms of the activities that are most commonly used and was also studied from self-report was walking 2 to 3 blocks and walking at a speed of 4 miles per hour. So we actually asked, well, how long would it take to walk 2 blocks at 4 miles per hour? And so the funny thing was that you had to figure out how long a block was in Chicago. Now, everybody who was working on this paper was in Chicago. So we said, well, let's go off Chicago because there's a block, there's an avenue. If you're anyone is from New York, you'll know that avenues and streets are very different. So the short side of a city block in Chicago is actually 330 feet. And I know this because I Googled that and I looked it up based on the overall streets and standards on the city of Chicago. The short side is 330, the long side is 660. If we took a conservative approach and said, let's say they can walk 2 blocks at 4 miles an hour, that's roughly 1.85 minutes. Now, as we discussed, we bounded those kind of times in minute periods. So the shortest kind of interval we could look at was 2 minutes, and so it was concordant and worked well. We'll talk about a sensitivity analysis we did to try to make sure that that actually worked pretty well. But essentially, we used a 2-minute bout of moderate to vigorous physical activity. Now, one thing that's important to kind of remember when we're looking at these measurements is that there is a possibility that the epochs may not align well with the actual activity that's being performed by the individual. And here's what I mean by that. Essentially, what happens is that if, let's say, I'm going to get my laser pointer now. Let's say that you have a 2-minute bout of activity. So this is above the threshold of activity and it lasts roughly 2 minutes. I apologize for my very poorly squiggly lines drawing of activity intensity. However, it spans 3 different minutes based on how the accelerometer itself cut the data. Then this patient would likely not be classified as meeting that threshold according to the threshold that we set forth in 2 minutes of continuous moderate to vigorous physical activity. And so that patient would be a fail. Now, it helps that we're looking over a period of 7 days in terms of identifying for the frequency. So more likely than not, that would not likely be a limiting factor in identifying those with a functional capacity, an adequate functional capacity. So our study cohort, we had some inclusion criteria, which was initially to generate the cohort, a revised cardiac risk index condition. So essentially they had to have at least one kind of condition that increased the overall risk, which was coronary artery disease. And we used the medical questionnaire to identify a yes response to coronary artery disease, angina, or myocardial infarction, all kind of qualified. And then there was heart failure, cerebrovascular disease, diabetes, and in particular, the way the RCRI works is that it has to have an insulin requirement. It can't just be a diagnosis of diabetes. And then chronic renal insufficiency, which is actually identified through labs that NHANES draws, or a yes response to receiving dialysis in the last 12 months. And the only exclusion criteria we initially had was missing questionnaire data. Essentially, obviously, if data was not complete from that aspect. In terms of the final cohort, there were a total of 14,631 participants in NHANES. Of those, with one or more RCRI clinical condition was 852. And then beyond that was complete physical function questions was 522, and that was our final cohort. Now we had set a threshold of at least 4 valid days of accelerometer wear time, essentially to say that that would be likely representative of individuals who had, well, 4 days is likely representative of their physical activity, their typical physical activity, and would likely have been able to identify a certain bout. There are variations, and I think Dr. Huizenschieß was kind of pioneered some, especially in older adults, looking at either NHANES and also NSHAP. But we made sure to kind of control for the amount of days of accelerometer time that was performed in the analysis. And then if you were to weight this cohort, so this is a complicated survey design, if you were to weight it, those 522 patients would represent about a little over 10 million persons in the United States. And so that was our final cohort that we had. Now we used a physical function questionnaire to identify those physical function questions that are typically used in the guidelines, and the goal was to mirror them as closely as possible. And so one of the differences was that sometimes they phrased it as walking for a quarter mile or 2 to 3 blocks, obviously because there are differences in how long a block is, but nonetheless, both were actually included in the actual statement that was read to the participant. And so we felt that it was similar or close enough that it should be sufficient. Here, they actually defined walking up 10 steps as a flight of stairs, and they didn't say walk, it was actually climb. And then the ability to perform house chores, lifting or carrying, preparing meals, and also walking between rooms on the same floor. Now, the last 3 we pretty much knew likely were not to be associated with inadequate functional capacity, or we would be surprised if they were, partly because they don't necessarily need to incur moderate activity intensity or not using that threshold. That being said, we continue to include them, partly because we wanted to make sure that they would, kind of confirm our results if they were not significant. And then with each question, it was associated with a difficulty level. No difficulty, some, much, unable to do, and do not do or do not participate in that activity. And our analysis kind of answered the question as to the cut point that we would choose for each question, because we used a classification and regression tree analysis. Essentially, we used a cart, which was ideal because, again, what we're trying to do is create a clinical decision tree to identify the optimal question and cut points that would be able to identify an individual who would be able to engage in moderate activity and hopefully be cleared for surgery. And so CART analyses essentially identifies those explanatory variables with the most explanatory power, essentially that would create more homogeny of the individual. So basically, more people who answer this question have a good functional capacity as opposed to those who don't. If you look at the sample tree over here, this is a sample tree that I think most people can relate to, which is using gender and age to identify which shirt preference they would buy in a store. Essentially, man versus woman, men who are old like polos, whereas men who are young like baseballs. Essentially, you're using those questions to create nodes or branches in the decision tree to identify those individuals who would more likely than not favor a certain shirt. Here, we're trying to identify individuals who are more likely than not to engage in moderate to intensity activity. And so it self-identifies the optimal split point rather than having to self-specify that. In terms of node restrictions, what you don't want is to have an overly complex tree and overfit your data, primarily because then it's only specific to your cohort and is really poorly generalizable. So we use a complexity parameter threshold of 10 to the -6, which is a common threshold appropriate for that. And then we split the cohort into a training and test data set. We would also use the random forest to identify the most important questions and the Gini impurity criterion to identify the accuracy of each question to identify which one would create the most homogeneous groups if removed from the actual model. And then we did a couple sensitivity analyses. We did 2 in particular. One is we used different durations of moderate activity to account for that 2-minute calculation. So we used 4- and 6-minute bouts as well, just to make sure that we were ensuring and not being, I guess, a little too generous with our assessments. And the other one was to include demographic and clinical conditions in the last group to see if there were any other predictors that might be a little bit more informative as opposed to just using physical function questions.
Daniel, can I stop you and just ask a quick question because I don't remember?
Whatever you like.
For the CART analysis, is it possible to do a CART analysis in like stratified samples? For example, let's say that the cut point for adults who were over 80 was a little different than the cut points for people who were under 80. Can you adjust and have multiple?
You can. Well, you can only have one. So you can make it so you could recursive it, meaning you could add a cut point here and then age again at a different level. You could do that. It makes it really complicated, and we actually restricted our tree. It's actually a really good question. We actually restricted our tree from doing that because we wanted to make sure that it wasn't overly complicated. With our primary analysis where we just used questions, we wanted to make sure that it wasn't at different levels because otherwise it just would have made it kind of completely unwieldy. But you'll see that I think in our sensitivity analysis, we actually kind of let it go like let it go wild. And then you can create any different kind of tree that you want with different cut points. Obviously, it just increases the complexity to a certain degree. The way it also works is that if it assesses all variables at one level, and at each other node, it will assess those variables again in a different order and not prioritize it to make sure that those interactions are actually established. In terms of the results, overall, about 73% of our patients had an adequate functional capacity, which is kind of what we would have expected, and it's consistent based on the literature. And inadequate was characterized primarily by older and shorter adults. You'll see that the age was 74 to 68, and so that's kind of consistent with what we would have expected. Older adults are typically less active. And then, and I you know, as I'm kind of reviewing this again, the fact that shorter individuals were more likely to be less active is kind of counterintuitive, just because if you're walking at a certain speed and you are shorter, then you're probably going to be doing more individual work. You're walking at a faster cadence. And so you imagine your intensity would be higher, but nonetheless, accelerometers would rate them to be shorter. I haven't seen anything. I don't know if you have, Megan.
No, I think this gets at some of the limitations of accelerometry. People with long legs are able to walk faster, and so it's picking up a higher MET, even though you're measuring speed, you're measuring the acceleration, which is what you're correlating with metabolic equivalence. In this case, you're actually not measuring energy expenditure. It might be higher in people who are shorter because it takes them more work to get that intensity of acceleration. So it's just a limitation of the accelerometer.
Yeah, again, we are using the surrogate measure for the direct measure, which is kind of what we've been doing. And the others are heart failure and stroke, which is completely understandable as to impacting the functional abilities of the individual. In terms of just looking at overall associations, there were only 3 questions that were actually associated with that 2-minute bout. One was a quarter mile, or the 2 to 3 blocks. The others was stairs and household chores, which is exactly what we would have expected to see. And the other 3 were not associated with the inadequate functional capacity. And so kind of those results were consistent with our a priori hypothesis that they shouldn't be. Now, here's where we kind of get into the pruned tree. So I'm not going to show you the final tree or the complete tree, which is very confusing in terms of the number of nodes or split points. But a node is essentially a split point where you have different kind of categories in terms of the homogeneity of kind of the actual, or they actually call it the purity of the actual split point of the population within that node. And essentially, this is the training set where we had 469, and the overall frequency is 70% of the outcome. And the primary question was the ability to walk up 10 stairs as no difficulty was the primary split point here. And it was followed by a second node of the ability to walk 2 to 3 blocks. What's fascinating is that at the end, it created a likelihood ratio for that group alone of 3.7, which based on the post-test probability would be a 90% adequate functional capacity based on the likelihood ratio, and the pre-test probability of about 72%. The problem with this is that overall for everybody else, which is roughly about a third of the population, is that it really poorly classifies them remarkably. And so it's really no better than an actual coin toss using those 2 questions, which are essentially the backbone of what we do clinically, and that we're really kind of doing a disservice to a certain degree to our patients. In terms of looking at the random forest analyses, it confirms how our tree was constructed, which is to say that walking a quarter mile and using walking upstairs are the 2 optimal questions to improve accuracy and decrease the Gini coefficient, which if you took them away would actually increase the heterogeneity of the groups, which is exactly what you don't want. And it should be known that all of the questions beat out the RCRI or any clinical condition in terms of identifying those with a reasonable functional capacity. In terms of the second aim, which was to identify differences in activity levels, so what was surprising was that, maybe it's not surprising, that there was an overall small frequency of moderate to vigorous physical activity that was actually present in the overall cohort, essentially, less than 2% for both groups. Nonetheless, what these questions really seem to get at, or at least this bout, is that overall, those with no not even a short bout, had no existence of moderate to vigorous physical activity in their overall weekly of wear time, which is really quite remarkable. And that in those who had a 2-minute bout, it was still a very small component of their overall activity. What was interesting was that there was a large difference in the overall active time of about 10% between those two groups, which again, based on the age, isn't surprising, but it's unclear as to what impact that level of activity actually has. In terms of our sensitivity analysis, the different durations of MVPA that was seen was actually kind of quite surprising, partly because for 4-minute duration, the frequency dropped down to 37%, and for 6 minutes, it dropped down to 27%, which isn't that much because you imagine that those people who are quite active are probably pretty active, much more so than the other population. What was fascinating was that no question actually improved prediction in terms of there was no nodes or branch points in any of our trees when we actually looked at the higher duration or the longer duration of moderate to vigorous physical activity. When we opened up the tree or the actual clinical decision point to demographics and clinical factors, not surprisingly, age became the dominant factor. And, you know, everyone always says age is just a number, but it really is actually a really important number that determines most things. And so in this case, it actually determined it was superior than any questions, just including stairs and walking a quarter mile, which you can see on the left are the second and third branch points after age. Whereas on the right, and you can see that there's kind of a discontinuity between, and maybe this is what you were getting at, using gender on one side, whereas you use stairs as a decision tree on the other side. Nonetheless, it's still actually quite poor in terms of identifying older adults who are at risk, unless you use a strict age criterion. And so our conclusion was that individual physical function questions really poorly classify patients with clinical conditions to identify adequate functional capacity as measured by objective accelerometers. Essentially, it's a poor method in terms of self-report to identify objective activity. And that short bouts of moderate to vigorous physical activity are actually associated with differences in overall active time in older adults. And it's actually kind of fascinating that such a small impact of moderate to vigorous physical activity can signify or identify significant differences in overall active time. What's also fascinating was around the time we were doing our paper, this paper also came out looking at functional capacity directly measured and suggesting that the actual gold standard or peak VO2 doesn't predict, in-hospital complications, myocardial infarction or death anymore in a large cohort. And so obviously surgery has advanced to a certain degree. What's fascinating though, is that a self-report questionnaire, a structured questionnaire that consists of 12 questions, actually did predict the primary outcome. And so it suggests that physical activity may be playing a larger role than the overall maximal exercise testing, especially in a larger population. So our next steps in terms of this question to understand the role of physical activity is to actually pilot a prospective observational cohort in major non-cardiac surgery using hip-worn accelerometers in a 7-day wear period to hopefully determine that association in terms of overall active time in moderate to vigorous physical activity and also discrete bouts, then also determine mediators and moderators of that relationship, because obviously that is a complete knowledge gap and unknown kind of in my field and my specialty. Maybe I'll pause for a second if anyone has any questions, because I do talk quickly. I don't know if anyone does or not.
So when you analyze data, you say you apply the weighting, right? Sampling weighting or whatever.
We actually didn't. We didn't when we did the CART analysis.
Did you consider, let's say, how can I say, sampling design, the stratification and clustering stuff?
Oh, you mean using those to generate or certain probability weights as to?
Kind of it will, you weigh the data, so you will have an unbiased estimate, but eventually it will affect the variance. So if you consider stratification and clustering, something like that.
Yeah, we didn't really have a clustering variable that we felt like we could reliably use based on the sampling structure of it.
I see. You mean you have a so-called PSU, right?
Yeah, there's a primary sampling
Haynes.
unit. Yeah.
Yeah.
So and again, this is primarily based on my conversations with Don Hedeker, who kind of supervised the statistical, design. And he didn't want to make inferences based off of the weighting, primarily because the methodology hadn't really been well described for CART.
Correct. Correct. Yeah, that's true.
And so to apply those weights and then change the variances, it's unclear if that would be better, or just add a different level of complexity to the actual model.
Yeah.
And so that's why we just used on the kind of like the observations that we had.
Okay.
Yeah.
Okay.
So
I agree.
It's a great question, and there's no right answer, I think. But that's what we chose to do.
Okay. Thank you.
Sure. Oh no, thanks.
This is so interesting to revisit, Daniel, by the way, even though I remember this is a couple years ago, I feel like it's nice to rethink about this. One thing that kind of struck me as we were talking is, in some ways, accelerometry is an estimate, a surrogate for actual energy expenditure. And I recall at the very beginning of your study, to set the context, describing that surgery itself, the exposure, is a stress, and it causes this whole physiologic response that increases energy expenditure. We don't really know how much additional energy is needed from baseline, for example, to recover from surgery, or how much energy is required to get through the stress of a surgery and the recovery of a surgery. It is possible to measure that objectively, and you could then relate that to an actual measure of energy expenditure tolerance over some time in individuals outside of accelerometry. Accelerometry, as you know, is only really measuring movement, but for people, for example, who have arthritis or other chronic conditions who have kind of inefficient energy expenditure with mobility, they will appear to be moving slower, even though they're expending a lot of energy to move. So they may actually have the cardiovascular capacity to withstand a certain level of energy expenditure, even though they're not able to mount the right acceleration in the accelerometer. So I would just be curious, and we can talk later about this, but I'd be curious how much energy it takes for an individual to get through a surgery. And can you more objectively than even accelerometry measure how much energy expenditure someone's actually doing day to day, their total energy expenditure in a week, as opposed to just their elective energy?
It's a really interesting thought. It has been looked at in terms of, I want to see energy expenditure typically measured through metabolic carts during recovery, I think. There's another group that's looking at what would be considered the operative stress score, based on the actual intensity of stress associated with the surgery, giving it a 1 through 5, but not actually directly, as you said, measuring energy expenditure during that recovery process. There has been some work, but as you said, it's still definitely at this point inadequate to identify that. But it would be fascinating to kind of understand that relationship. And if there's kind of a mismatch, are those patients much more likely to have complications or not? So
there's a professor emeriti at UW-Madison who used to be at U of C and basically did the very first measurement of total energy expenditure using doubly labeled water in humans. Mm-hmm. It's super easy. Patients just drink like an isotope and then they pee and you measure their pee. But it would be feasible to do that. He's not too far, and I think there are people on campus that do that now. So just as a future work idea, we should talk more about that.
We definitely should talk about that. I did not know that was as accessible here as it was.
Yeah.
I guess I'm going to talk about the second paper that I kind of wanted to focus on. I have a couple more, but which also related to the second aspect of the guidelines, which is to say the frequency of preoperative cardiac stress testing, and primarily to look at if it's even still increasing based on the trend that was from 1995 to about 2006, and also to determine compliance with those guidelines, and secondarily to identify if it actually reduces at least pharmacological stress testing to a reduction in cardiovascular outcomes such as myocardial infarction and cardiac arrest. And so for this, we actually used Rubin Market Scan, which we have a subscription to here at the University of Chicago. And it essentially is private insurance claims. And essentially it's employee-based coverage, which does include Medicare Advantage. So that's a big plus or an advantage because it does include a Medicare population. The only problem is it does not include traditional Medicare, which is typically known to be older and less well. So that is unfortunately a significant exclusion. The types of claims that were available were inpatient, outpatient, pharmacy, and lab claims using ICD-9 and also 10 because it spans the 2015 inclusion or transition to ICD-10 and also current procedural terminology codes for outpatient services. This does actually exclude the unemployed and also Medicaid, but nonetheless, Rubin Market Scan actually represents about 185 million adults in addition to families as well. So our inclusion criteria was actually interesting. We were looking at after patients undergoing a primary hip and knee arthroplasty, and we chose that cohort very deliberately. And that was because those are individuals who would automatically or more likely than not be labeled to have a poor functional capacity. And so we were looking after a cohort to try to get at the underlying, I don't want to say baseline stress testing rate, but the frequency of stress testing in patients that would likely be labeled a poor functional capacity. And the exclusion criteria was essentially those having an emergent procedure, obviously because it's not planned. And we used a primary diagnosis of osteoarthritis as that. The other alternative was to use emergency medicine claims. So essentially a visit to the emergency medicine department within 1 or 2 days prior to the surgery. The problem was that sometimes they can be delayed, in which case then it kind of gets really messy, whereas nobody's really going for a hip or knee replacement with a primary diagnosis of osteoarthritis under an emergent condition. We excluded those under 18 years of age. Also, we would exclude not the first surgery observed in the database. Essentially, it had to be the first surgery, just because the first surgery may impact the kind of results in the second. And then they needed active enrollment for at least 12 months prior to the surgery, so we could actually identify all of their clinical conditions that were associated with it, because we used those documented conditions to identify the past medical history, in particular, the revised cardiac risk index conditions. And then if they didn't have drug data, they were only included for half of the analysis, partly because we needed to identify insulin-dependent diabetes mellitus, and we didn't want to include them into the compliance with the guidelines analysis, just in the trend line. So here's our cohort. 185 million adults were assessed for eligibility. We identified 1.3 million during that period of time that had a hip or knee arthroplasty. And then you can see we excluded about 500,000 of them for those exclusion criteria. And then about 115,000 were excluded for the secondary analysis, which is for guideline compliance or adherence, and also cardiac events. Now, one of the hard parts is to try to link certain kind of tests with the actual procedure itself. And so our primary outcome was a cardiac stress test within 2 months of the surgical procedure date. And we chose 2 months partly because historically it's been between 30 days and 2 months is typically associated with the preoperative procedure. Partly because they're typically, ordered within that time frame. What we decided to do was a kind of a sensitivity analysis to see what the overall frequency of stress testing was in our cohort before the procedure, and you can see the kind of figure on the right. It's the baseline frequency of our cohort of stress tests ordered by month. And so 0 is essentially the procedure date. And then we looked at each month before as the overall frequency. And you can see that, past 3 months, there's typically a flat 5% frequency of overall stress testing in the actual kind of group. And then what you can see is a steep rise or incline at about the 2-month mark. and which we hypothesize, and is likely correct, that those were directly related to the upcoming procedure. And so we can definitely kind of associate those two procedures together. And so that's why we use 2 months as our cutoff. Secondary outcomes that we identified were myocardial infarction as assessed through ICD-9 and 10 codes, as well as cardiac arrest. Now, the analysis that we wanted to see, one is we wanted to see a trend analysis, partly because we wanted to see if there was a continued increase or decrease based on responses to the guidelines. And also, for that, we used a joint point trend analysis. And the nice thing about joint point is that it will actually automatically identify specific joint points across trend lines, and will actually identify them, as opposed to being able to have to manually identify them through visualizing the data. Reviewers really don't like that. And then we also used a Cochrane-Mansell-Hansel test to evaluate differences in complications. We did not adjust for baseline characteristics, primarily because if what we're looking to evaluate is the presence of a stress test, what we were trying to see is it's only based off of one clinical condition. So we stratified based off of that clinical condition, but not on other comorbidities or other issues based on how the guidelines are implemented. And then we used a generalized estimating equation with a logit link to identify characteristics associated with testing. And we did cluster by metropolitan statistical area, and partly because there's a significant variation among different locations amongst the United States. And this is, I guess, like a heat map of the US. And, we could only kind of get as granular as the MSA, or the metropolitan statistical area. There's significant differences in terms of hospital variation, and that's kind of been well described. Here you can still see that there's significant variation based on the actual location, anywhere from 2 to 16% frequency before actual, the procedure. And so we clustered based off of MSA. In terms of the overall results, the overall frequency of testing was 10.4%, which is actually really surprising, partly because in that previous study of low-risk procedures, it was about 6.5%, still increasing. So about 1 in 10 older adults, or adults before a hip or knee arthroplasty, would actually obtain a preoperative stress test. What was surprising was there was no difference between procedure, partly because it's always thought that a hip is much more stressful than the actual knee itself. However, there was no difference, as you can see on the top area here, in terms of procedure between total hip and knee. No differences in the overall frequency, or at least statistically significant, but so large as to be like kind of, I would say, trivial. And then there was a kind of propensity for men to have more frequency of testing as opposed to women. And then those who had a test were older, and then also much more likely to have a history of ischemic heart disease. What was surprising, and I guess not necessarily in our hypothesis, was that there was a significant decrease in testing starting in the third quarter of 2006. And partly, you can see the inflection point here, current rise in the annual percent change of 0.65%, and then a net decrease that has persisted throughout the entirety of the study period. And you can see the yellow line is essentially the observed rate, and the aqua line is essentially the joint point smooth estimate of trends. And what was surprising is that it was similar to the actual overall decrease in testing in non-surgical Medicare patients. This is a publication from, again, I think a 20% sample of Medicare patients and overall frequency of testing throughout the years. You can see an inflection point at around 2006, which is actually similar to what we observed as well. What's surprising is that this is actually reflective of other inflection points that we saw. And this is the year before the actual procedure in our existing cohort, to see if they had any existing change in the frequency of stress testing. And also we found a change at about 2006 in terms of this. So just to kind of create some degree of a sensitivity analysis as to whether it was in response to any guideline changes, which a new set came out in 2007, or if it was actually just in response to secular changes of the overall frequency to order these types of tests. What was probably the most surprising was the persistent overuse of testing. Essentially about 50% were unnecessary per the guidelines. And I can say that because the green, this is a figure in terms of the overall number of individuals who underwent a stress test before surgery. And you can see those with no clinical conditions made up about half of those who had a test in terms of green. And so you can suggest that overall compliance, because the guidelines recommend someone with 0 clinical risk factors, even if they did have a poor functional capacity, should not receive a stress test. And so it's compliance with the actual clinical recommendations is actually quite poor. Nonetheless,
sorry, do you have any insight from clinical practice why there is an overuse among people without any existing chronic illnesses?
We don't. I would say that given previous patterns, it's typically provider dependent. It makes up the lion's share of the burden of who orders these tests. As I think I mentioned a little earlier, there are financial incentives to do it, which I'll highlight a little bit in, I think, two slides. In terms of capitated versus non-capitated plans, those that have some incentive to kind of decrease costs, there's a reduction in stress testing. But it's kind of a persistent overuse of testing. And there's no real kind of like insight as to what it would take to actually kind of really make a dent further into this unnecessary use. And the reason why is because there's still an overall low frequency in this cohort of major cardiac complications, surprisingly. And you can see in terms of being stratified by clinical condition, 0 versus 1 over here. If you have 0 conditions, then the frequency of, an MI or cardiac arrest is essentially less than 0.3%. The likelihood of any test to be able to benefit that population is exceedingly low. What's surprising is that even if you do have one condition, while the frequency is significantly higher, it's really no different as to whether you had a test or not. Now, what we did was we said, okay, well, wait a second, maybe we're selecting inappropriately for patients who were, had a test earlier, or, because it's unlikely that you're going to get a repeat test within the same year. So we said, okay, fine. So we excluded anybody who had a stress test more than 2 months beforehand, but within that year. And so we said, what are the frequencies of complications? And ultimately, they were essentially the same. Maybe there was a slight difference in terms of those who had a preoperative stress test was higher than those without. But otherwise, there was not significant difference, and not so to justify the actual testing. In terms of characteristics that were associated with testing, I would say age was one of the primary determinants, especially if you reach 85 and you're undergoing a hip or knee. With about 1 in 5 undergoing a test, men were more likely to actually get tested, in addition to more clinical conditions. And also, non-capitated insurance plans were much more likely to actually have a test as opposed to those who were not capitated. And roughly, we concluded that preoperative cardiac stress testing has decreased, but still overuse is pretty rampant. Wasn't associated with improved outcomes. And the major limitation, though, is not identifying patients delayed from surgery due to stress test results. And actually, there was a, less is more from JAMA Internal Medicine that was actually based on our study, and actually cited kind of our study to look at the unintended consequences of testing, which is this patient, which is a 75-year-old male presented for hip arthroplasty with inappropriate referral for preoperative stress testing, had 0 clinical risk factors, but was unable to climb stairs. And so because they used that stairs question, went for, had a stress test, which demonstrated significant coronary artery disease. The problem and the issue is that by identification of that disease, he wasn't eligible for CABG because of a calcified aorta, and so unable to cannulate for cardiopulmonary bypass. So not eligible for CABG to actually fix it. An attempted PCI that led to a ruptured coronary artery vessel that led to a complication cascade, and actually not even getting the procedure itself. So the patient hasn't had the hip arthroplasty and is still dealing with complications of the cardiac treatment itself. And this kind of gets to the challenge of identifying patient-level impact of preoperative testing, which is to say there are a bunch of different patients that exist. There are those at, patient 1, which has a surgical evaluation, then goes for a preoperative evaluation, then goes for whatever testing, but nonetheless progresses to the surgery and does just fine. And then there are those who have the surgical evaluation, pre-op evaluation, the testing, and then are kind of intervened upon in some way, and then either go to surgery or actually maybe not actually even go to surgery due to harm from the actual intervention. And then there's patient 3, which has the same thing, but the surgery is actually canceled. And there is a paucity of data in terms of trying to identify the implications of those tests, other than kind of who we can actually observe because they had the surgery. And so that's, in terms of future directions, what we would like to do and are kind of working on it is determine the generalizability of our finding, but also identify the unintended effects of those tests, whether it's patient harm or cancellations, and also identify those, I guess for lack of a better term, clinical cascades as a result of testing that leads to incidental findings that can't actually be intervened upon, which is really very challenging and something we're trying to work on.
Thank you, Dr. Rubin, for this awesome presentation.
Wait,
sorry, do you still have more?
Well, yes and no. I mean, I was like, how long do I go? Because, you know.
Get some more.
Well, no, I'm going to stop, but I got it. So yeah, there's that. Don't worry. Wait for it. You know, I just wanted to kind of circle back to another study we did together, which was, you know, I opened with, oh my gosh, old people are dying. It's so sad. And, you know, how are we doing on mortality for older adults? And this was the study that, you know, we did recently in terms of elective and emergent major abdominal surgical procedures from 2002 to 2014. And, you know, essentially the frequency of procedures is going down, partly because, which is kind of contrary to popular belief, which is, you know, everybody's getting older and we're doing more surgeries. But in terms of comparison, if you wanted to look at the overall mortality, there's been almost a halving of mortality for colorectal resections for older adults over 65 in those kind of intervening 30 or 40 years. So there has been really some significant gains in treatments of older adults and surgical patients in general, partly because screening is much better and also operative care. Now I'm done. Okay, great.
No, I'm sorry to cut you off. I wanted to make sure we had a few minutes for questions from anyone. Again, this was really great to revisit all of this work. I had a couple of questions that you sort of answered here in the last couple of slides, but I'll just mention them anyway. You know, it's interesting that, you know, the cardiac complication rate is so low in all patients going to surgery. My first question is it because we're taking healthier patients to surgery and excluding all the people who are not healthy? So we're doing a better job in other ways outside of functional capacity of changing those, changing who's going to surgery. But then my second question is, if it's not related to that and it's because we're just kicking butt on the surgery side, then why do a stress test at all if people are, you know, the risk of having those cardiovascular perioperative complications? Why do the cardiovascular stress test and one at all? And I guess as a kind of related to that, the perioperative mortality rates in general are so low, not just from cardiovascular disease, but from all cause. Is there any interest, do you think, among surgery and anesthesiologists to think less about, are they just going to live or die, but are they going to recover from the surgery itself, and using functional capacity in whatever shape it's measured to predict people who regain all of their capacity months to a year later?
So I'm going to try to do all three of those. I think in terms of the cardiac complications, there's a thought that it's actually higher than we think it is. There's a big push to recognize myocardial injury after non-cardiac surgery as opposed to MI. Super controversial, but if you accept it, it's about 1 in 5 people have it. And then you're like, my gosh, it's everywhere. What can we do? In terms of stopping people from getting stress tests, I think there's still that kind of thought that we can pharmacologically identify patients who are at risk of ischemic disease and dying on the operating room table, which is a catastrophic cause. And I think that fear likely drives a lot of practitioners. I will say I finally ordered my first cardiac stress test in the preoperative clinic recently, and that was for a really kind of sick, decompensated patient who, you know, I think would have needed it regardless of whether they were going to proceed or not. And then in terms of the last, you know, I think one thing that I found most striking in terms of the last study I did, which I didn't really get to talk about, but showed that essentially mortality is improving, but patients are being discharged to post-acute care. And part of that can be LTACs or SNFs, and whether they actually end up getting home. I think there's a a renewed focus on that, it's just very hard to approach it because patients, typically fall into two camps. One is improved quality of life. Some may just want the quantity of life, and it's very hard to identify those and have those discussions. And surgeons, I know, feel very vested in terms of, I think, seeing the patient through to the end, partly because they've invested a lot. Whether that's an appropriate kind of approach or not is questionable.
Super.
I will ask a quick question if I can.
Yes.
Yes. Hi, I'm Jennifer Caputo. I'm in sociology, postdoc in sociology. And sorry to sort of backtrack, I didn't realize that you were going to jump into a different study, but I had a question about the first project you were doing. I think it's really interesting to think about, how people are responding to questions about their health on surveys. And it's something that I've thought about a lot. And all of the different processes that go into that. And I wonder, one of the questions that I had for you was whether you took a look at those people who were reporting that they were doing all of these physical activities, but had the really low activity scores, and whether you noticed anything or any characteristics or patterns in that group of people.
We haven't really been able to identify kind of certain patterns. What it seems is that, at least I can say, at least my direct experience in clinic is that oftentimes in the context of healthcare, there is a desire to appear well in domains that are not actively being sought after. So for example, there's an incentive for a patient to seem well if they want the surgery. If they feel like there's going to be a barrier in between their ability to receive care, then they will say, yep, I'm great. I'm healthy. Yeah, I can do that. Yeah, that's no problem. And I think that would probably be the most common theme we see, at least within clinic, is that desire. And obviously there's variability. There are people who want to seem unwell in certain ways if they think it will get them better care, in terms of oh no, I need that test. Yeah, I need that. And so I think that part of it is that perception by patients in terms of, I think and I don't want to say it like that because I probably do the same thing though, is kind of
Yeah. I think I'm just interested, I guess. So one of the ongoing projects that I've been working on is looking at comparing people's self-rated health on surveys to sort of a latent health score that we create using different objective measures, and looking at gaps between that. And so one thing that we really notice in particular is that the major pattern is that as people age, they tend to be a lot more optimistic about their health and the things that they can do. And we see a lot of inaccuracy cropping up there. And I know in Haynes, I haven't worked with it, but I know it's an older sample too. So yeah.
I think what you should also take a look at is ICU survivors. So basically people who go through the ICU and, after, let's say, respiratory failure, which is pretty prevalent these days with COVID. And I can try to find who it is who's kind of leading some of this research, but suggests that, what we would deem to be kind of poor health, some individuals have either accommodated to their current state or are so optimistic as to where they are right now. And I wonder if there's some overlap with older adults. They're like, well, I've made it this far. I think I'm doing great. And so it's fascinating how, we in our current state would look at that and be like, oh, that's really not good. Where they're like, hey, I can still tie my shoes. How about that?
Yeah, it's all about your reference group. I think that's a big chunk of it too.
Yeah.
But thank you so much for.
Oh, no, thank you. Great questions.
Well, I think we are at time. I really appreciate Dr. Rubin, you taking time out of your busy clinical day to come and present to us. And thank you for all who stuck around to the end. Excellent questions. We will see everybody again next week, Thursday.
Thanks so much.
Take care, everyone.
All right, bye.
Good day.